Super delighted to introduce Cindy Martin, a good friend and colleague who heads up the heart failure transplant MCS program here at Houston Methodist and is nicely positioned to highlight the impact of the Impella 5.5 as it relates to guiding decision making in the context of percutaneous support, bridge to maybe more surgical or durable support, or heart transplant. Cindy?
All right, thank you. Thank you, Jerry. Thank you, everybody. Thanks for the invitation. I think thanks for the topic. It's one of those that we took to look about, and it's kind of, what do we mean by this? What do we mean by looking at, what does the Impella tell us? And I think I'll try to walk us through some of the data and see if I can answer some of those questions. So I have, unfortunately as well, no pertinent disclosures. When we talk about cardiogenic shock, I think you've seen this schema. This is from the American Heart Association of just looking at the management pathway. But as heart failure physicians and as when we're looking at different things, I think all of us, our goal is to figure out how to maintain sufficient cardiac support. And we've heard lots of different methods about how that may be done, but obviously that's our number one goal. The second, obviously, is to maximize survival and reduce complications while determining the appropriate exit strategy. And that is, sometimes may take a little bit of time. Sometimes it's pretty quick. Sometimes that may be recovery. Sometimes that may be transplant. But it's just trying to figure out how we keep them in that place while figuring out which is their best option. And then finally, I think this is where the crux of the matter is if we're able to move them to a different exit strategy, how do we figure out what the superior option for that is? What is their best exit strategy? Not only short term, but long term. So we'll see if we can tackle a little bit of that. So why are we even kind of talking about the Impella situation? And the clicker is dying. There we go. And so I think this is a nice little meta-analysis that was just published earlier this year, which actually looks at the outcomes of Impella in a wide variety of cardiogenic shock. And I don't expect you to look at read all of these things, but what it tells you is with Impella support, we're getting really good outcomes. And so with our Impella 5.0, you're around 68%. With your Impella 5.5, you're above 70%. Almost 75% of these people are surviving to discharge. So we have a good temporary option. Where do they move forward? And how does that really change when we look at going from a temporary MCS? Should we go to a durable MCS? And obviously right now that would be the HeartMate 3, or should we go to transplant? And I'm going to try to stay out of the controversy of what the allocation system makes it easy to do. And really try to look at maybe what does the physiology tell us, and what does the anatomy tell us. And so when we look at this, obviously there's been some early data that's coming out. This was published just recently out of UCLA, which looks at the UNOS data looking at from 2016 to 2021. These were people who were taking straight from temporary MCS, so Impella in particularly, and in this talk when we're talking about temporary MCS, we can basically exchange Impella because purposely taking out all of ECMO and balloon pump. So all of this data is really looking at Impella support as a task was given me. To see, okay, if we take somebody off Impella to transplant, how they're going to do. And that may seem a little simple now, but you got to remember, this was new. Like back a couple years ago, a lot of our heart failure, our transplant teams, we were looking at our support of these really sick patients with ECMO. And going from ECMO to transplant, the early data didn't look so good. And so then we're asking the question of, well, what about if we take them from Impella to transplant? What does that look like? And so this was, again, kind of showed that you can see that the data in that upper right-hand corner there, you can see that the outcomes of patients who were taken from Impella to transplant was no different than those who were transplanted off of durable support. Now this data was from, again, back in 2016 to 2021, and so our durable VAD data, and this was only about 24% were HeartMate 3, and this was only 29% were the Impella 5.5. So this was some of our earlier things. And the other thing that we have to remember is these patients who went for transplant, all of the Impella patients were really high status. Okay, so your old 1A, 1B in your old criteria, obviously when we moved over to new criteria, they were status 2. And your durable VADs, about 70% of those were status 3 or higher. So that's not, again, we're comparing apples to oranges a little bit of our VAD because obviously your status 4 are your people who are at home or doing well. Status 3, by definition, you have to have an LVAD complication. But still, kind of saying maybe these were similar kind of sick patients, the outcome looked pretty reasonable. I will also kind of show in this graphic in that first up panel, if you can see the kind of substantial increase in Impella support that happened in 2018. And so you kind of go along, and then all of a sudden when the allocation changed, we really see a lot more. Now, having said that, that's also when we started getting the Impella 5.5. So I think we can't completely blame that, but kind of very temporally interesting. And then you can see the areas where we use Impella support more frequently. One of the other publications that looked at this was, again, another UNOS analysis. This is from the team at Pittsburgh, which actually took UNOS starting from 2018. So this is all data with the new allocation system. And again, what you can see is from 2018 to 2022, the substantial increase in the percentage of patients who were transplanted straight from Impella support to transplant as opposed to going to durable VAD. And what we saw, again, that there really was no statistically significant change in their outcome. That we saw the 1-year survival of patients who were transplanted straight off Impella was 95%. The 1-year survival of people transplanted off durable VAD was 90%. And so it was trend that maybe the Impella people actually did a little bit better. But again, I will remind you that the Impella patients were all status 2. And so by definition, if you're on Impella, you're status 2. It doesn't matter if you're walking around the hospital on no medications, have a blood pressure of 150/90, you're still a status 2. Your VAD patients who were transplanted were status 3 or higher, so again, maybe sick. But one of the things that actually they looked at is, they also looked at, did they have any other complications? Did we see change in rejection, pacemaker or stroke? And all of those were pretty equal. The hospital stay was a little bit quicker, interestingly enough, in patients who were transplanted off Impella. But one of the things that I think that we gloss over a little bit is you look at the time on the wait list. And so the time on the wait list for somebody who was transplanted off an Impella, if you look at it, you can see is only about 12.5 days. The time of wait list on somebody on a durable VAD was 223 days. So yes, it took them longer to get to transplant, but they lived 212 days longer before they went on to their transplant. And as we know, once we go to transplant, the clock starts. And so I think we always have to keep that in mind a little bit. We'll come back to how quickly these people were transplanted off Impella and maybe some implications of that as well. But though if we say, okay, well maybe it's better to take these patients to a VAD, so let's go from Impella to VAD, then by essence you're saying a lot of these patients are then obviously going to be transplanted off of a durable VAD. And so this was a publication that came out from the Tufts groups that looked at the difference in survival versus the new and the old allocation. And so this was from 2015 to 2017 and then 2018 to 2020, or sorry, 2018 to 2020. And what you saw was actually in patients who had a durable VAD who underwent transplant, their survival was actually slightly worse with the new allocation compared to the old allocation. It went from 88% in the new allocation compared to 92% in the old allocation. But when they actually went back in and did some adjustments, especially for ischemic time of the donor, there was actually no significant difference. The other thing I will raise your attention to is when you look at patients who were on the wait list. So if you were on the wait list with a durable VAD, you actually had a lower chance of being delisted because of either worsening conditions or death. That was from 7% down to 4%, but you also had a lower chance of undergoing transplantation in 1 year, so down from 57% to 51%. So all in all, again, these patients, when we're looking at the new system with the durable LVAD, probably the survival is pretty close, and they're being listed less. If we compare this with Impella, this was an interesting study that came out of the Medical University of South Carolina. They actually took all the Impella registry that we had from UNOS, and this is data from 2010 to 2021, which looked at patients who went straight from Impella to transplant. And again, if we compared, they actually compared the difference between Impella 5 and Impella 5.5, and what we saw there wasn't much difference between those two as far as survival or death on the wait list. But again, the average time for people waiting for Impella for transplant was 10 to 14 days. And this study actually highlighted of when you see the people who had a death or deterioration, that average time was 41 to 46 days. So I think we have to remember with these temporary devices for short term, the outcome's looking pretty good. But if we're having to have people wait longer and longer on these temporary devices, we can say may, see more and more complications, and maybe we're going to see differences in survival. So then, what about if we have what's called a bridge to bridge? And so this was a very interesting publication that has came out 2 years ago, actually from the Johns Hopkins group, again, a UNOS registry. And what they did is they broke it down and they said, okay, let's take all the patients who went from temporary MCS straight to transplant, and then temporary MCS to VAD, then to transplant. So a bridge to a bridge. And you'll see the data here. They looked at both Impella as well as balloon pump as well as ECMO. And the short answer is if you went from bridge to bridge or bridge to transplant, your outcomes were the same at the time of transplant. And also, again, you're looking at the mortality, rejection, stroke, all of these things were basically the same if you did a bridge to bridge or if you just did bridge to transplant. Now, my last thing I'm going to say, but maybe there is a group of patients that aren't going to do as well on durable VAD. And we know all those exist. There's some of those that we know just anatomically, or they're not VAD candidates for various other reasons. But I think one of the banes of our existence is right heart failure. Like, how do we predict who's going to have right heart failure? And I think this is a very interesting place where the Impella 5.5 may be helpful. And this is data that's actually from our Houston Methodist group, where they looked and they took people who were supported on Impella. And we said, okay, let's look at those who developed right heart failure and those who didn't develop right heart failure. And if you look at their data before, what you see pre-VAD implantation, they don't really look that much different. If anything, the people who did not develop right heart failure had worse hemodynamics pre than those who did. We did see, again, some complications, and I just put that up there because these temporary devices aren't free. We have to remember that. But if we looked and we did the Euroscore of trying to look at, okay, how, where are we? We can see the Euromax score. It's kind of hard to say. If you look at the people who had right heart failure, when they started out, a lot of people did okay, but after they had the Impella, this is where we really saw the right heart failure really change. Again, the people who had no right heart failure when they started prior to Impella maybe actually did have worse numbers, but after the Impella that we saw a switch. And what the group was actually able to show is it really is their change in their hemodynamics with Impella support that predicted. And so if they get better, and if you get your lower your RA pressure, the lower the RA to wedge pressure, your PAPI gets better with Impella, that's a really good predictor that you're probably going to do okay with your VAD. If you don't, then maybe you should look at a different option. So with this, I'll just wrap up in saying we do know that there's a growing use of temporary MCS as bridge to transplant. There are favorable outcomes with post-transplant outcomes with this. There is wait list removal between while they're waiting does seem to be similar. And I think we can't lose sight of the concept of total treatment years gained. And we have to keep that in mind when we're making our choices. And then maybe that there's some hemodynamics during Impella bridge may provide a risk stratification for RV failure that can identify a cohort that may be best served with a direct bridge to transplant strategy. And so with that, I'll stop. I'm happy to answer questions.
Cindy, thank you for a great talk, and we're going to jump right in. Starvel's had his hand up first, and then we'll hear from Michael.
Thank you so much, Cindy. So I really enjoyed how you went through the bridging options. So Veli Topkara and the Columbia group with us published the UNOS data showing that after the allocation change with the accelerated way to transplant people, the people that they were delisted for recovery went 8 times down, or it was 8 times higher before 2018. And the patients didn't change in 2018. So what's your comment, and how can we incentivize with the new system that is coming so people can really wait on Impella 5.5 or even go to durable if we need more time, so we can recover hearts and put donors back to the pool for the other people that they don't have this option, right?
Yeah, no, I completely agree. And for the sake of time, I didn't even touch on that, but you're 100% right. When we're bridging and when we're going straight from a temporary MCS to transplant, you saw the averages between 12 and 14 days in every study. There's no time to recover. You can't even assess for recovery, honestly, in that standpoint. You can get an idea of who may be showing you something, but we really just threw, the recovery out the window, when we looked at a lot of these patients. And I think it's a hugely valid point. I think, how do we change it? I'm hopeful as we're working on the new continuous distribution system. There's been a lot of focus based on that, and a lot of focus going to be on time on VAD as a very big variable to be able to help move people who are doing well on their VAD. Because like I said, most of the people who are getting transplanted right now are the people who have complications. But if we can get people who still get that time that they're well on their VAD, I think their outcomes are going to be even better, and I think we'll start seeing a little bit of a shift. So I completely agree. I think we have to find that balance. Of course, there are some people who will always need to go straight from temporary MCS to transplant, but I think that we've gotten ahead of ourselves.
Michael, and then we have a question over here to my right after.
Sure. Yeah. So we have a busy 5-5 program as a bridge to transplant that's been very successful. But a comment that you made that was interesting and really important is understanding the outcomes in longer term, short-term support. So our average wait time is not 10 days in Region 1. It's now extended for certain blood types. So blood type O, we're now extending out to 28 days, and we often see it much longer than that. I think as a community, we don't, the UNOS analysis, they don't collect the granularity of data that we need as it relates to understanding best practices and different management practices, again, for how we handle these patients, as well as the associated complication risks. We don't, there are some registries out there, but we don't have an Intermax type temp MCS registry. That would be really important, because I could say, we've certainly looked at risk of post-transplant infections, fungal infections, as well as stroke. And stroke not related necessarily to the Impella itself, but potentially to cannulation techniques in the axillary artery and posterior circulation stroke. So I say this, I see people nodding their heads, but these are one-offs. And it's like the story of the HeartMate 2 with seeing hemolysis and people mumbling about it, but until we collectively pool our data together, we're not going to have a good understanding. And we're not going to learn how to move forward with managing these patients, map targets, anticoagulation protocols, et cetera.
No, completely agree. I think, we started to do some work, and at least on our initial kind of preliminary analysis, it looks like about that 30 days is where you start to get the crossover for outcomes on temporary MCS versus going straight to VAD. If you have them on longer than 30 days, then your risk of dying and not doing as well really starts to increase. And I think it's all the reasons you talked about. It's not just them sitting there, but it is, it's not just their heart. It is their infection risk. It is, like you said, the thrombus risk of, when you have to take this Impella out, when it's been sitting there for a long time, where does everything go? I think we all see some of those things. I do say, and I think, it'll be interesting to see in the interim between coming up in the next few months when the new guidelines for the allocation system change. And so those who aren't familiar, previously it had been like once you kind of become status 2 that you can kind of stay status 2 forever, but there's been a new update to that says you still have to continue to meet the criteria, so you basically still have to be in shock. So regardless if you have your Impella, you still have to be on inotropes and still be in shock to maintain your status 2 criteria, otherwise you're going to drop down to status 3. Which I think is going to increase some of the time, which I think we'll start seeing. I have a feeling we're going to see a little bit more transitioning back, going to VADs in those situations. Obviously, continuous distribution, hopefully we'll be able to answer those questions better. But I will also say, and just a plug for those of you who also serve on the Heart Committee, to give us patience as we serve on the UNOS Heart Committee, because the first time that we do continuous distribution, there's going to be a lot of problems because we just don't have all the data that we need to make it the way we need it to be. And so we're just all going to have to work together to continue to get that as we evolve moving forward.
Final quick question. Or comment.
Actually, you answered my question with the new updates, because the problem is now 2018 allocation came for to shorten the wait list time and then shorten to the list. Mm-hmm. Now I know that is in 1 year that list grow 15% and it will grow more and more, and the waiting time is, I think there should be some changes to be done, and we go back to VAD, durable VADs also.
Yeah, I think the pendulum is going to swing back. I think it made a big swing too far. I think it's on its way back. We just have to figure out where the sweet spot is.
So more to come. Cindy,
More
thank
to
you.
come. Thank you.